for joining us for this second Mesothelioma UK interview. This is a pre-recorded interview, and I'm delighted to welcome Mr. John Edwards, who's a consultant thoracic surgeon working in Sheffield. And for those of you who don't know me, I'm Liz Darlison, Mesothelioma UK, so consultant nurse at the University Hospital of Leicester. So we thought we'd be running a series of interviews with people who might be able to offer you some insights, some reassurance about the current situation for people living with mesothelioma in light of the COVID pandemic. So John and I have known each other for many years. We've just been talking about it actually, and we think probably about 22 years when John first came to University Hospitals of Leicester to undertake his PhD, which was in mesothelioma. So he's one of the reasons that I got involved in mesothelioma right at the outset, because I joined a team of surgeons, oncologists, physicians who were really committed to mesothelioma even 25 years ago, when not a lot was known about the disease, as we've just been reminiscing. So John is one of the reasons that I got involved in meso. He's been committed professionally to mesothelioma for so long. And in fact, I can remember, John, the first time we held a Mesothelioma UK Patient Carer Day. I remember what a big event that was for you, and you got quite emotional at the time from what I remember. So welcome, John, and thank you. The first thing that I wanted to ask you is how the COVID pandemic has impacted on your practice. And 75%
rehab nurses have set fire to a taster. Sorry.
And a portion of that will be mesothelioma patients. So how has the COVID pandemic impacted on that?
I'm sorry, you're going to love this. We've got a fire alarm going on in the background.
Well, we'll just carry on regardless, because that's live. But this is a live,
so I think we'll just carry on, but I'll have to mute and unmute just in case it doesn't go off, but hopefully it will. But no, thank you, Liz, for that introduction, and I guess yes, my passion for meso does go back a very long time, and yeah, and I think we were both very lucky that we started off in what was in those times an absolute dream team in Leicester, and we're still, as you said, we're still both riding that wave that started 20-something years ago. And I guess the issue that we have at the moment is that we've got big challenges with COVID-19 and what that means for our patients and what that means for our practice. And I'm very grateful for the opportunity to have a chat with you about that. As you rightly said, I feel very passionate about this, and still occasionally do get a little bit emotional with and about patients, and yeah, that's something that is part of what we do. It's a
no harm in that, John. We're all human.
It's an emotional disease. It's an emotional disease, and and I think the fact that it attracts people that have that kind of caring mentality, I think is a good thing.
So how has it impacted, the COVID pandemic, on your thinking about mesothelioma particularly?
Sure.
So the Mars 2 study, patients seeking out surgical investigations or surgical
yes, I think it's affecting things from beginning to end, and that we can go through those fairly quickly, I guess. So if we think from the pathway from the presentation of the patient through to the final challenging treatment decisions and the treatment that we make, it's clearly affecting patients all the way along that pathway. So one of the things that we've noticed, if looking at the data from referrals from the general practitioners, and I've been speaking to a colleague of mine in Nottingham who is chair of the commissioning group there, and they've noticed that the referrals from patients through the cancer pathway is running at about 20% of what it should be at the current time, and that suggests effectively that we have patients not willing to come forward, or perhaps it's that the access to primary care is an issue. either way, it's something that is of concern at the moment, and we don't quite know how that's going to pan out. I guess an important thing that we all strive to do is to try and avoid emergency presentations of patients, and knowing that the most common symptom of meso patients is breathlessness. What we want to try and avoid in a way is for patients to end up in the emergency departments in extremis, and if we can encourage patients to come forward and to seek advice from their GP, then we can go down the conventional cancer pathways through clinics with the chest physicians, which are still running, and see and encourage people to go through the normal route of referral. Then that's the very first part of the pathway, and something that we need to try and get right.
Are you still able to operate, do diagnostic procedures at this current time?
So diagnostic procedures are on a kind of needs basis. The units are still offering thoracoscopy, but the problem with that is that it takes longer to do so. The big issue that we have with COVID-19 is that we don't truly know who is negative. And it's relatively easy to identify people that have symptoms because they tell us. But the problem that we have is not knowing who's negative, and therefore, because we don't have a test that truly proves the negative, at the current time what we're having to do is to assume that everybody that we operate on, both in local anaesthetic procedures and also general anaesthetic procedures, we have to assume that they are positive. And that means for the patient it's potentially a bit more frightening if they are awake, because we have to wear fairly intimidating personal protective equipment with the masks and the visors, which we would not normally wear for a local anaesthetic procedure. It means that the rooms are stripped out, and it is a much more of a threatening environment, and we need to make sure that we ensure patients accept that is how it is, but we still want to make sure that patients go through with the diagnostic procedures if we can.
And what if a patient was in the middle of the Mars 2 study, for instance, and was randomised to surgery in the last week or so? Is that surgery still able to go ahead?
Yeah. As you well know, I'm involved intimately in the Mars 2 study of surgery, and that's something again that I have a lot of passion about, making sure that we get the evidence for the things that we do, and surgery being a fairly big intervention. It's really important that we get that information. Effectively, we've had to look at new recruitment into Mars 2, and we feel that at the current time we struggle to feel that that's something that we should do, and part of that is because of the unknown risks of surgery in the setting of the COVID pandemic. And what we wouldn't want is to suddenly have a cohort of patients where it's going to be where the risks are greater, both for surgery and non-surgery. So almost every cancer clinical trial almost in the world has paused to new recruitment. So that's the kind of the easy bit, and I've certainly seen patients who are currently waiting, who have early stage disease and don't have too much in the way of symptoms, have a diagnosis of mesothelioma, and we're waiting to see what happens, and we have these patients very much in mind as to what the options will be. Coming back to those that have already been randomised or are coming up to randomisation, that again is a more difficult scenario. As of a few weeks ago, when we first discussed this, we didn't know what the impact of COVID-19 would be on our intensive care unit beds. Patients having extended perirectomy decortication, the Mars 2 operation, have to go to an intensive care unit post-op, and therefore we have to be able to have that capability before we start the operation. So for patients that are in the study at the current time, it's really up to the individual unit, to the surgical unit, to discuss with the oncologist and also with the patients as to whether they firstly have that capacity to even offer surgery, because it may be that they don't. We know that there are intensive care units around the country that are still sort of in over capacity. But having said that, we are able to offer some of our regular cancer and other major surgery that requires intensive care beds. So we would have to take that on an individual basis. But beyond that, there's actually a slightly bigger question as to whether a patient should go forward to an operation in the current setting. And one of the studies that has come, I mean, there's been a lot of research that's come out of COVID-19. It's astonishing how quickly very significant research studies have come from a concept to recruiting patients in an incredibly short length of time.
In days.
It's astonishing. It's astonishing. I mean, the biggest study, which is not a surgical study, it's called Recovery, is for patients predominantly on intensive care units. It has been completely astonishing. So the ethics process for gaining ethical approval for a research study can often take weeks and weeks and weeks, and from application to it being granted took 8 hours, and that is just unheard of. Not only that,
there's going to be a lot of learning going.
Oh, absolutely. Not only that, the recruitment to that study has just been unbelievable. So I understand that in the first week they recruited 1,000 patients into a randomized study of different types of treatment for patients with COVID-19. And within about 3 weeks, they'd hit over 5,000 patients. And that's astonishing. When you think about Mars 2, that we're aiming for, we're at about 300 after 5 years, after a huge amount of effort to get that far. I mean, the scale is just mind-boggling. But I think
on that note, John, can I just ask you about what work you're involved in to understand COVID better,
sure,
and to help overcome the disruptions, and also probably just mention about cancer surgical hubs?
Yeah,
I don't know. I mean, some areas are identifying one of their 3 hospitals as a surgical site,
sure,
and others are looking at hubs. So
yeah, so I mean, the latter question is really evolving, but I think in terms of the understanding, I think that's very important for patients. The study that I've got involved in quite a big way is actually an observational study called COVID Surge, and this is run through the National Institute for Health and Research, the NIHR, which is the NHS research body. They have a Centre for Global Health in the University of Birmingham, and they have a surgical division within that. And they've produced some remarkable studies looking at the impact of surgery in different areas on a global basis. And they set up a study to look at 2 aspects of patients having surgery with respect to the COVID pandemic. The first study that was set up is the so-called COVID Surge, and this is looking at the risks of patients that develop COVID that also have an operation of whatever type in whatever specialty, and this is again a global study. And it's been set up really within the last 3 weeks. And in that time, as I understand it, there's been about 4,000 cases registered on an anonymized database. So it's been set up in such a way that it can go through the regulatory process very quickly. And the very first paper from COVID Surge has already been submitted to the Lancet Journal following analysis over the last weekend. I can't say too much about that yet because it's still jiggling around a little bit, but that's the first 4, the outcomes of surgery in the first 400 or so patients. And these are patients
NHS patients.
Yeah, so I'll come to that in a second.
patients?
So these are patients that are not just having COVID and then presenting to hospital requiring an emergency operation, but these are also patients that have elective operations of all different types, including thoracic surgery, that then at some point within the 30 days after surgery develop the COVID disease. And the number of thoracic patients in that is relatively small, but that's because things are still being entered and being analysed. And what they wanted to do was to look at that 30-day outcome. Well, actually, if you look back to 30 days ago, how the world has changed since the 28th of March. But on the data of the 17th of March, when they analysed the data from for those patients where they then had 30 days of follow-up, there aren't a huge number of patients in any particular specialty. But what does seem to be apparent is that the risks of developing COVID in either before or after surgery are very significant. And it's too early really to understand precisely what that is, but it is a great concern. And that poses a concern, as you said in your question. It poses a great concern in terms of the reintroduction of surgical services, and not just for meso and the MARS-2 study, but also for lung cancer and cancer surgery in general. So it's really by putting a lot of cases into this study that we will learn what are the risks. We don't know what the numbers of patients. I mean, I think if I remember rightly, there were at just 18 patients having thoracic surgery in that list in that first paper, but we've now got about 300 or so, and so is
that in globally or in the UK?
It tends to be globally. So
Globally.
about a third of the cases are UK based, but there's therefore significant numbers from other countries.
And what advice, if we've got people who are caught in that situation where they are deemed suitable for surgery and randomised surgery in the MARS-2 study, but are waiting for a safe environment to enable them to have that surgery, what advice would you give those patients in these weeks that they feel like they're treading water and a bit
I mean it's
trapped in the circumstance?
And don't forget, it's not just surgery, it's also the chemotherapy. And
what advice would you give patients?
And there are also studies going on looking at cancer, at COVID in non-surgical cancer patients, because that also is a big concern. I've had acquaintances, not patients, but actually friends rather than acquaintances than patients who are undergoing chemotherapy at the moment and have had COVID whilst having a very low white blood count, and that is a very worrying time. I can't underline that enough. So I think the whole of cancer treatment and how we deliver it, not just surgery, is really up for consideration, and quite how we deliver chemotherapy and surgery is to be hotly debated and reviewed. The thing about surgery is that we can't do surgery in a patient's home. It may be that we can offer other types of treatment without a visit to hospital, but we can't do that with surgery. And hence the NHS is looking very closely at whether and how we could identify hubs that are apparently COVID-free. We don't quite know how those are going to work, whether that's going to be on an institutional basis or whether it will even be on a city basis, as to whether we will have COVID-free sort of cancer surgery hospitals in a different city. So we don't know how that will work, and how that would work for MARS-2 is a big issue. And the reason for that is when you look at the centres that are conducting the surgery for MARS-2, because it does require the surgeon, they are all centres that have a very big part to play in the management of COVID, and you just need to look at the numbers of patients on the NHS websites that have been admitted to the surgical centres in London, as well as in Leicester and Sheffield, and also in Glasgow, and it makes you realise that actually to think about how to do it for meso patients is more challenging. If you've got a bowel cancer, you can kind of go anywhere. For a regular lung cancer, there are plenty of places you can go to. But for MARS2, because for meso surgery, because it does require a very close team, it poses much greater challenges to determine how we can reintroduce the surgical service.
But it sounds as if there's a lot of effort going into trying to create a safe environment so
certainly.
that we can get back to business as normal,
certainly
in a new normal.
But I think the crucial thing to remember here was, if you are a patient who are coming towards randomisation, or even have been randomised to surgery, and we're not quite sure how it's going to happen, I think we have to go, take a step back and realise what MARS2 is about. We have to remember that we are testing treatment A versus treatment B, where one includes surgery and the other doesn't. And actually the whole premise of the study is that we don't know whether surgery is better, the same, or worse than chemotherapy alone. So it's not as if a patient is randomised to surgery and for whatever reason we can't deliver on that randomisation, it's not as if that patient would necessarily be missing out on proven treatment. And I think it's really important to remember that. And similarly, if it's the same as taking a step further back again, thinking about recruitment into the study to start with, if it's something that we knew was of proven benefits, then we wouldn't be doing the study. And it's the same with any study of different drugs and so forth. We have to remember that actually standard treatment is pretty good. But then there's the question as to whether we can currently deliver the standard treatment of pemetrexed and a platinum chemotherapy regime. And that's another question entirely.
That is happening. It's on an individual basis. People are being assessed. But, so I guess there's so many uncertainties with COVID that, there's no point me asking you about timelines. I think it's reassuring to hear that there's a lot of work going, global studies being led by the UK, looking at the impact so that we can create that safe environment around people so we can get back to a new normal.
Absolutely.
But in the meantime, John, have you got any kind of words of wisdom or hope that you could offer to patients and families currently at home who are feeling, having mesothelioma is a sharp end of life's edge, and added that COVID pandemic, and we are people that they look to for hope and for options. And are there any words of hope and wisdom that you'd like to share with people and their families?
No, absolutely. And I think the psychological aspects of cancer are the most important aspects. And if there's one intervention, well, there's two interventions. If there's two things that we can do, that patients can do to improve their psychological well-being, I think the first is to talk. And we can't stress how important it is to talk and to share our concerns and worries. And that may be with a mirror. It may be with family, it may be with the wonderful support service that Mesothelioma UK provides. It may be that it has to be a local team, but it doesn't matter. There are people that will listen, that get the fact that this is a really awkward situation for patients with meso. So I think talking is one thing that is absolutely essential, and sharing those concerns. The second thing, which is a little bit more difficult, is exercise, and is staying as physically fit as possible. And we know that we've known that for years. We know that we've had, how do I put it? Probably the one of the longest standing and most helpful meso warriors ever came up with the wonderful Petal initiative with Meso UK, and I think the aspect of that about exercise is really important. How do you do that whilst trying to socially isolate as much as possible? That's a big challenge. If a patient has a garden, if they live somewhere where they can get out into an exercise out of the house, be it within the garden or beyond on streets or in parks, then that's great. Obviously, preserving as much distance as possible. But equally, there are patients who are not going to be able to do that. If a patient lives in a flat without stairs, it makes exercise if you can manage them. But again, not every patient can.
We've certainly been doing an awful lot of advocating exercise.
Absolutely.
We've got Julie Roberts doing some movement videos live going out on our Facebook, and you know, even a can of beans in each arm, it doesn't matter.
Absolutely.
To improve your muscle tone.
Absolutely.
I think on that note, John, I'm gonna call time on us. Our comms team have suggested keep it to 20 minutes if you can, because it's keep the conversation fresh.
You know me, I can always talk. If you give me an hour, I'll take two.
Me too. And it's something we're both passionate about. We could rattle on forever, but I think it must be of some reassurance to people to see that there are experts like you, complete anoraks, as I would call you, about mesothelioma, committed to the cause, who are still doing everything you can to help get us back on track in a safe way. And and there are things that people can do. I think if we manage to identify a patient with mesothelioma who has had surgery through the COVID pandemic at some point, I think we'll try and interview them and get them online as well, just to share their experience, because again, that will give, surgery isn't for everybody, even if it is, an option clinically. For some people, it's something they don't want to, they don't want to explore, but for others it is, and we have to respect that while we're awaiting. John, can Meso UK invite you back in a few weeks perhaps, and we'll see where we've got to then?
Give me the opportunity. You know that I will do anything for Meso UK.
Yeah, you're a gentleman. Thank you very much, John. I'll allow you to sign off because you've been responsible for the recording.
Talking to the team again soon, and as you rightly say, I think it's really important to realise that you're not forgotten. That we are doing a lot behind the scenes to make sure that our management and care for meso patients is going to be back on track as soon as possible.
Wonderful, thank you.
Take care.